of the Indian Express Explained Live, earlier known as E Explained, our series of online explanatory conversations with domain experts and authorities on specific subjects. I am Monojit Majumdar, editor for explanatory journalism at the Indian Express. As some of you might be knowing, we have been doing these events for more than 5 years now. And I always begin with a line about Explained itself, a section of the Indian Express that is very special to us, very dear to us, very important to us. We think of Explained, the content in our paper and on our website, as well as in events such as this one, as being rooted in the news, but going beyond just the news. So it is context, it is background, it is connecting the dots, it is analysis. And in today's shrill, noisy news environment, which is often a lot of loud, uninformed opinion, an explanation of the news. Why is something happening? What will happen from here on? How is it going to impact you? Is perhaps as important as the news itself. This evening, we will talk about where we stand in the battle against the pandemic right now, what lessons we have learned from the second wave, and what we can expect in the next few months from here onward. To discuss some of these questions, we have with us this evening Dr. Matthew Verghese, Senior Consultant at St. Stephen's Hospital, Delhi. Dr. Verghese, welcome to the Indian Express. We thank you for your time and we are honored to host you. Many of you would have seen Dr. Verghese's amazingly clear video on COVID, some 6.5 million views when I last checked. And I'm sure this interaction will be every bit as enlightening and as informative. I hope even more so. Speaking with Dr. Verghese, along with me will be my colleague, Conan Sharif. Conan, you have been covering health for the Indian Express for several years now, and you've been watching this pandemic very closely and reporting on it every single day from the beginning. Conan will begin with a very short presentation on the state of the pandemic today, after which we will have our conversation with Dr. Verghese. That will last for about 45 minutes, after which Dr. Verghese will take some questions from the audience. A large number of you have logged on for perhaps another half an hour. Today's Explained event is brought to you by our presenting partner, Kia Biotech, and our associate partners, Plutus IAS and the ITM group of institutions. My thanks to our partners. And thank you, all of you, for joining us, and welcome once again. Conan.
Before we start, we would like to play the AVs of our sponsors, because with whom support we are able to take this
Absolutely,
session.
absolutely.
Kia Biotech products ensure long-lasting 360-degree protection from the virus and germs. Duro Kia Edge, the long-lasting hand sanitizer. Spray on both sides of your hands and allow it to dry. Do not rub. Your hands are protected for 24 hours or till you wash them. Duro Kia S, the long-lasting surface disinfectant. Spray on soft and hand surfaces and allow it to dry. Do not wipe before drying. It kills germs within 60 seconds, and nanoformulation coating provides protection for 35 days. Duro Kia M, the unique mask coating product. Spray on your mask and allow it to dry before you wear. Your mask kills virus till you wash them or discard. Great! Now you are ready to step out.
Plutus IAS during COVID-19 crisis, offering online fresh batches for the year 21, 22, 23. Plutus has experienced faculties, interactive classes,
Yeah. So we are beyond looking at just the numbers. Today, as we stand, we have more than 11 lakh active cases. At the peak, we had more than 30 lakh active cases in the first and second week of May. But broadly looking at the second wave, we saw three things that changed in the second wave. First, we saw a very highly transmissible variant of the coronavirus, what we now call as a Delta variant. This Delta variant was infecting more number of people. So therefore, we saw a large caseload in the country. We also saw a significantly large number of hospitalizations. The second significant thing we saw in the second wave is that the virus moved from the large metropolitan cities to the rural parts of India. In fact, in the second week of May, when India was experiencing its peak, we saw almost 530 districts in the country reporting more than 10% positivity rate. And third, of course, we saw a huge surge in hospitalization, significantly in the metros, which meant that our health systems were completely overwhelmed. So beyond these three large patterns, we saw patterns at every level. First, we saw the symptoms. I am quoting you this data from the registry of the ICMR with the data that was submitted by the health ministry during the peak. The first big change that we saw in the symptoms, especially in the hospitalized patient, was that in the second wave, shortness of breath was the most significant symptom. In the first wave, when we saw shortness of breath in around 42% of the patients, that had jumped to almost 48%. However, the other three common symptoms, which was the dry cough, loss of smell, sore throat, all of them significantly dropped in the hospitalized patients. So the big takeaway was the fact that shortness of breath had become the most significant symptom in hospitalized patients. The second thing at the hospitalization per se was the fact that the requirement of oxygen in hospitalized patients in the first wave stood around somewhere around 42%. That jumped to 55%. So there was a huge significant increase in the requirement of oxygen in the hospitals. Second, what we saw was there was a significant or an incremental decrease in mechanical ventilation in the first wave, which around 38% of patients required mechanical ventilation. That dropped to around 28%. Can we move on to the next slide? Yeah. So the age-wise breakup. So in the age-wise breakup, what happened was that the people above 40 years still continued to remain the biggest chunk of the patients, hospitalized patients, which is almost around 70%. This signifying that they are the most vulnerable population who require the maximum resources at all levels of our fight against the pandemic. Then, as we move on 20 to 40 years, that was around 24%, and 0 to 19 was around 4%. So even if you look at the numbers, we still are in the same sort of framework where the 45 plus still continue to be the most vulnerable population. In the clinical management, then we saw significant changes in the second wave. So at the home isolation level, what we saw is that the health ministry came up with various protocols. First is that it advised use of ivermectin for patients if their fever lasts for 2 to 5 days. It also said that if your fever was lasting for more than 7 days, you could then use mild oral steroids. But however, both of these were on the prescription of the doctors. So that's the first big significant change we saw in home isolation. At the hospital level, however, we saw convalescent plasma therapy being dropped from the National Clinical Management Protocol. However, a lot of hospitals continued to use this therapy. At the testing level, we saw for the first time that the government recommended the rapid antigen test in rural areas, predominantly because of lack of RT-PCR testing. We should remember that the rapid antigen test has a high rate of false negatives. However, because the surge was so high, the government recommended the rapid antigen test. Second, we saw that in the later part of the pandemic of the second wave, they said that hospital admissions can be allowed without a positive RT-PCR test. But however, this came in the later part of the pandemic. And then in the vaccination strategy, of course, the first thing we saw was 18 to 44 being included in the vaccination drive. But there were three other very important changes in the vaccination. First is the lactating mothers were made eligible for vaccination. Second, we saw a big change in the dosage. the government said that people who have tested positive and then recovered, that they should defer their vaccination by 3 months. And then we saw that one of the vaccine, which is the most widely used vaccine in the country right now, Covishield, they said that the second dose now has to be administered after 12 weeks, which is the only country which is now administering the second dose after 12 weeks. Then the most recently that we've seen is supplementary infection associated with COVID-19. We are now seeing a significant amount of cases of mucormycosis reported in many parts of the country. We're seeing a significant number of cases in Gujarat, Maharashtra, and Delhi. So these were the large trends that we saw during the second wave. So to begin with, we begin with the symptoms. We saw a number of people in this wave complaining of shortness in breath. There was drop in the classical COVID-19 symptoms, the sore throat, the cough. We saw a huge demand for oxygen at the hospital level. Why did this happen? What is the science behind the drop in oxygen and COVID-19?
Thank you so much for having me for this session. It's very interesting, the statistics that you presented. It just goes to show the spectrum was evolving as the Delta variant was spreading its activity across communities. The sheer number of cases having breathlessness was a selection bias, basically because large number of people were infected, and of this, the subset of people that needed oxygenation were higher as expected. Many of them could not even get tests done because testing needed 3 days waiting sometimes. At the peak of the epidemic, to get an appointment for testing was also difficult. So there were delays from that front. And the simple thing that we saw was in the earlier phase also, we had a clearer understanding of what total numbers were there and what percentages were. In this, the numbers are way beyond our capacity for testing, way beyond our capacity to handling in the hospital. So the numbers that came up, most of them were a selection bias of cases who had need for oxygenation. Others were told to stay at home. When they contacted, is there a bed? Is there a bed? Do you have breathlessness? Do you have saturation drop? You stay at home. You don't have it, stay at home. So there is a selection bias but nobody did these statistics can be accurate only if you do population-based surveys. So if you did a house-to-house survey and found out how many of them had COVID positive, how many of them had breathlessness, and then of that percentage, compare with the previous percentage, you will have an accurate data. So that needs population studies, which are very difficult, very, very time consuming, very expensive to do, and may not be as safe. Engaging these people in going from house to house may not be safe at all, to subject them to the risk of exposing them to this. So I think it's a matter of detail. It doesn't matter. Breathlessness was the most important symptom, and that confirms the fact that this virus leads to a problem in your lungs. That's the number one problem. That's what we needed to address. That's the baseline that I would say. As far as the symptoms were concerned, again, in the list of cases that I was following up, over 350 of them have been documenting. What I found was, I didn't find loose motions in your list. Loose motions as a percentage were definitely higher in the early part of the disease. So the timing also was important. In the earlier phase, also loose motion was there, but they happened usually on the 9th or the 10th day. In this phase, loose motion was the first symptom, or after the second or third day, they had loose motion. So all the symptoms were getting fast forwarded to the earlier part of the disease, symptomatology. So that is the other thing, including anosmia and ageusia, loss of taste. That's ageusia. Anosmia is loss of smell. Both were there in many patients. In the last wave, it was seen on the 7th, 8th, or the 9th day. When I talk to patients, I'll say, oh, you might be having an anosmia today. Yes, sir, I have it from night. That's usually the 8th or the 9th day. This time it was a third day. It was the fourth day they had anosmia. So the difference that I saw, the spectrum remained the same. There may be minor differences in percentages, which if you give it to a statistician, might say that these are not statistically significant differences. But the importance was the symptoms were occurring at a much earlier phase in the disease than the previous wave. So the virus was far more infective, far more contagious. In the last wave, one member in a family, or at best two members in the family. In this wave, every member in the family, including the housemaid and the driver in upper class homes. So that is what we found. Consistently, everyone was affected. So the virus was far more contagious, far more aggressive in its symptomatology. But I think my suspicion is, I stand corrected, based on population studies. I wouldn't rely on hospital-based studies alone, because that will give you a skew on who went to hospital with what symptom. The bias would be purely breathlessness.
So, sir, just a follow up of the same answer then. We have population based evidence that though this variant is more transmissible, but there is
Yes.
very less data that this variant could cause much more severe disease. But what is your learning from the hospital level? Whether this variant is more severe, is it causing more severe form of infection?
I didn't think so. I didn't think so. It is just the sheer overwhelming numbers that we saw. So there was a selection base of cases going to the hospital being more serious than in the previous wave. Previous wave, our capacity was not fully utilized. We had spare capacity. In my hospital, we had 320 beds dedicated for corona patients. We did not use all of them in the last wave. We went beyond capacity in this wave. So the capacity is overwhelming. So there is an overwhelming capacity, and therefore there is a selection bias of more serious patients being chosen for admission. And the others were told, hold on, you wait. If there is a bed, we will keep you in. So that's a selection bias. I don't think seriously that is it. And you mentioned the statistics on the oxygen ventilatory requirement. That's a very, very interesting statistic. In the previous wave, you had ventilators available and they were used for the critically ill patients. In this wave, we had two learnings. One, internationally, globally, there is a learning that in coronavirus, so-called pneumonia, it is not a true viral pneumonia, it's an autoimmune coagulopathy, which is causing the clotting of the blood in your capillaries and veins of your lung that causes the picture of pneumonia.
Yeah.
Ventilatory oxygenation is not safe for the patient. In ventilatory oxygenation, to use a medical term, you want to recruit more alveoli which are not diseased. In this case, recruiting those alveoli which are so-called not diseased, they're actually, the alveolar spaces are intact, but they have dead alveoli there. They are dead because blood supply has been cut off. So pushing air into them through a ventilator can cause more harm. So alveolar recruitment using ventilators can cause more harm. This understanding was far more clear in this epidemic. And therefore, as far as possible, the doctors would try to do the levels of oxygen which were non-invasive, which means you don't put a tube into your windpipe and you don't use a machine to do the ventilation. This is called non-invasive ventilation. And the non-invasive ventilation can go from the mildest little tubes in your nose, and you have the oxygen flow meter giving you 1, 2, 3 liters or 4 liters. Beyond that, you have a mask there. If your requirement goes higher, 5, 6 liters beyond that it goes, then you do what is known as a non-rebreathing mask. So many of the patients, families would know, they would be told to go and buy an RBM mask. An RBM mask. The poor people, and they know their patient is ill, they know the patient is sick, they have been told to get a mask, they're not sure how far they can get it from, how easily they can get it, how much does it cost, all those things. In many hospitals, they were given the prescription, go and buy it. The NRBM mask can give you up to 15 liters of oxygen. In the earlier phase, you would put those beyond this, you might be put on what is known as a ventilatory support. Now, in this phase, no. They were being put on high flow nasal catheter. So, with this, from 15 liters, you could go up to 60 liters of oxygenation. 15 to 60 liters. All this is without a tube in your windpipe, without a machine pushing air into your airway. So, this was the difference because of the technical understanding that this disease does not tolerate mechanical ventilation as well. But then push comes to shove, pushed against the wall, you have no choice. If your saturation is not maintained, then you try proning, then you try the other methods, maybe BiPAP or CPAP, again non-invasive. And the last resort is the ventilation. And then there is one more level which is there, which the outcome is very difficult to predict in the very severe cases where even a ventilation is also not working. It's something like a dialysis machine for kidney patients. It's an oxygenation machine which is extracorporeal. Corpus means body. Extracorporeal means outside the body, membrane oxygenator. So instead of your lungs doing your oxygenation of blood, there is a membrane across which the exchange of oxygen is happening. So extracorporeal membrane oxygenation. Horrendously expensive machine, horrendously expensive tubings and connections, and maintenance is expensive. So very few hospitals provide that. But anyway, that is the end of the stage of your ventilatory capacity.
Yeah. So my next question, the biggest chunk of the active cases was still in the home isolation, but patients still didn't know what is a moderate infection, a mild infection. We saw indiscriminate consumption of antibiotics for a viral infection in home isolation. We saw azithromycin, doxycycline, ivermectin, which was recommended by the government itself. And in fact, there was a large use of steroids even for people whose oxygen saturation had not really dropped below 94. Do we need to do more on creating awareness on effective home isolation?
The problem was the protocols were based on mild, moderate, and severe. So we have the protocol which was laid out by AIMS and ICMR. We had mild disease, moderate disease, and severe disease. The moderate disease, the criteria was respiratory rate more than 24 per minute. But how do you count the respiratory rate? You needed to have an education campaign of people. How do you count? Or a healthcare volunteer who could be trained to do that. Or the other criteria was looking at the oxygen saturation, target oxygen saturation, how much is it? Based on that, you had your mild, moderate disease criteria. Whereas what we found was that the disease has clear timeline patterns. So to keep people at home based on purely breathlessness, you stay at home until your breathlessness reaches the level where the oxygen saturation drops to such and such level, is wanting people to have a digital sensor or wanting people to know how to count your breaths. Most people don't know how to count. You need to train people how to do it. You train your volunteers how to do it, train your family members how to do that. So those are criteria that are there. But having said that, the policy that needed to be clearly understood, and that would have come if we had real-time research by clinicians and clinical research workers. Here we had the entire system overwhelmed, the entire team of physicians and allied physicians, medical specialties, all of them were recruited. My own doctors in orthopedic department were also recruited for taking care of patients because the numbers were so overwhelming. And because the numbers were so overwhelming, we had no choice but to take care of it in such a way that we limited the number of patients coming in. But the one that stayed at home, to keep them at home, that is where you needed to understand the timelines. To keep them at home based on the breathlessness or saturation was, in my understanding, not scientific enough. Because For a person to have a drop in saturation to 92%, your lungs have to be compromised by more than two-thirds of its normal capacity. This is clear physiology. Two-thirds of its capacity may vary. In some person, it may be 50%. In some, maybe it will be two-thirds. But it's somewhere between 50% to two-thirds, the lung capacity has to be compromised before your saturation drops or your breathlessness comes beyond 30 per minute. That is the time when this you definitely need hospitalization. You definitely need to be having oxygenation. So these are the two things which are little difficult. It has not been emphasized globally, I would say. And globally, the need was based on your saturation and your breathlessness and your need for getting help for support for breathing. And that was done based on your saturation monitoring. Now, my understanding clearly told me, and this I understood right from the first wave itself, where I found that patients were having problems on timelines very clearly. It's predictable. In fact, the first draft paper I wrote, I called it the predictables in an unpredictable disease. The timelines were very predictable when they were having. There's one more difference which you did not highlight because it's not, clearly documented like that. In the previous wave, the patients became serious on the seventh day from the first symptom. And that is the recommendation for starting of steroids when they're becoming serious. And their cytokine storm is really a storm. But in this wave, I found most of them were having a serious turn to the disease on the fifth day or the sixth day. So the disease had advanced in its fast forward mode by 2 days. And therefore, in the previous day, it was easy to recommend that you have steroids not before 7 days have passed, which is valid, very valid in the previous wave. In this wave, what we found that most of them needed the intervention fifth or the sixth day, but clearly not before that, because before that is too risky. Before that, those patients staying at home, telling them to have steroids is dangerous if they have not crossed the fifth day, because you will prevent the body antibodies from generating because you're suppressing immunity with steroids. The body antibodies are not generated and they will prevent the virus from, the body antibodies normally prevent the virus from multiplying. If the body antibodies are suppressed, the virus will multiply, viremia will get prolonged, the disease will unnecessarily get prolonged. We do not, however, the other mistake for home-based care, as mentioned, was the antibiotic recommendation. The early antibiotic recommendation, actually, if you really see history of medicine, one of the classical papers which talked about viral pneumonias was pneumonias in children. Measles. Measles is a viral disease which has a very effective vaccine. But the virus causes the pneumonia. In a pneumonia, there is swelling in the air spaces of the lung. And because of the swelling, the air spaces get filled with fluid, inflammatory fluid. So that is, all the air spaces are blocked. Few are intact, and that is where you give ventilation. And then, because there is fluid there, and the commensal bacteria in the lungs now get a chance to multiply. And they found that in measles pneumonia, starting the prophylactic antibiotic early on in the disease is useful. However, the pathology post-mortem study in this disease very clearly showed it is not a pneumonia. The picture described by a pathologist for a lung pneumonia is, medical doctors would know, those of you listening, is called hepatization, where the lung, which is normally having lots of air spaces, looks like the liver, which has no airspace. So hepatization of lung happens in pneumonia. In this, there is no hepatization. Hepatization happens only after the 8th or the 9th day when the bacterial pneumonia comes up. Until then, there is no hepatization. Until then, there is no need for giving prophylactic antibiotics. This is not like measles pneumonia. This is not a viral pneumonia. It is an autoimmune mediated coagulation of blood in the blood vessels, and therefore causing a failure of exchange of oxygen between air and the blood blood in the blood vessels. There is no circulation of blood, therefore there is no oxygenation, and therefore this is different from that pneumonia. So prophylactic antibiotics, azithromycin, doxycycline, to my understanding, was a mistake. I stand corrected. If somebody can come out with a randomized control trial or sufficient data from research saying that no, it made a difference. To our understanding, any number of patients. So when I used to talk to patients, I used to talk to them morning and evening, and I used to call them as I would add you on to my Schindler's list. That's the expression I used. I'll add you on to my. Many people call me. The word went around the people who knew me. They said, "Sir, please, can you add me on to your Schindler's list?" I said, "Fine. I'll call you morning and evening and keep track with you." And I would take 2-3 hours trying to talk to them, just trying to understand what is happening. On the fifth day, what is the most consistent symptom that they had to indicate a cytokine storm? In the previous wave, it was seventh day, but in this wave, it is usually fever, which was there in more than 45% of cases. Fever, which is suddenly turning high grade from 99, goes up to 102. From 98.4, which is normal on the third, fourth day, suddenly jumps up to 100, 101. That is the first sign of a cytokine shower going on to a storm. That is the time to intervene. So you needed to give clear messages to the masses at large. Look here, this is what you need to watch out for. This is what you need to take. There is no role for antibiotics at this stage. By giving antibiotics to hundreds of thousands of people across the country, you created a shortage of doxycycline, you created a shortage of azithromycin, and then these are very efficient drugs for the elderly who are developing lower respiratory infection or pneumonia. They have excellent drugs which are useful. But today, everyone has had it. So the bacteria that is now left behind would all be resistant to azithromycin and doxycycline. So you've encouraged a community population of bacteria that is resistant to doxycycline and azithromycin. That's all that is done. So what was I doing? My patient, whom I suspected is going for a bacterial pneumonia, I had to choose some other antibiotic.
So then let's move then to antivirals, the repurposed drugs, which remdesivir. There are huge concerns regarding the clinical management protocol that it's still not uniform. When we come to remdesivir, we know that it can be used when there is a fall in oxygen saturation, when the CT or the chest show infiltrates, usually on day 5, like you were pointing out, in day 7. In fact, AIIMS director said that it should not be given too late, because then you have more of cytokine storm rather than having the infection. Could you explain why there has been no uniformity as to when to administer this antivirals, this repurposed antivirals?
I have been an avid reader of literature on coronavirus. Basically, my curiosity was arisen when I first read the report in November 2019 in Nature on the new virus, and subsequently when the pandemic was declared. And I had a big advantage, and that everyone else can follow it. You can download every article on coronavirus or COVID-19 free of cost. Otherwise, peer-reviewed journals, scientific journals, you can only see the abstract, you can't see the full text. In this disease, because it is a pandemic, because it is a global disease, all journals made it freely accessible. So I took it upon myself to read as many articles as possible. Do you know the criteria for inclusion study? Even for that paper which recommended steroid, which is a UK paper, Dexona as dexamethasone as being efficient in saving more lives, the criteria was admission based or moderate to severe cases. Your admission is based on so many criteria, especially when your overwhelming capacity of beds in your hospitals. How is your admission decided on? Availability of beds, availability of contacts, availability of other factors which decide on when you are admitted. So the criteria for the selection of these cases have to be more rigid. So when you read the papers, you find the loopholes there. More important, because the these are repurposed drugs. So many of the audiences may not know what is a repurposed drug. A drug which has been invented for a particular disease is meant for that particular disease. If it is being used for some other disease, it can be and investigated for another disease, it will be a repurposed drug. Or if it is being allowed to be used in another disease, it's called an off-label use. So both these have been done in the case of coronavirus. So the repurposed drug, they felt that because it was tried in Ebola virus, it had probably some benefit. They tried in this. The problem in the proof generation in any of these activities is, when do you start the medicine? At what stage? In the viremia stage. Because it is an antiviral. It is either modifying virus replication or virus entry or virus, in your body circulation. So that phase is a very narrow window of opportunity of 5 or 6 days. Beyond that, if you wait, your remdesivir is the primary problem in COVID is not your viral viremia. Primary problem is the autoimmune reaction triggered by the virus. So if you give remdesivir after the autoimmune has been triggered, it's not going to work. Before the triggering, maybe it can work. But to prove that is difficult. Why? Look at the recovery rate. Look at the last wave. What was the recovery rate? It went up to 98%. So if 98% of people are getting recovered, to prove that this drug is effective, you have to have a very large sample size and very large, over 10,000, 20,000, 30,000 studies of, of various phases of the disease. That is extremely expensive, very difficult to do, especially in the situation of a pandemic, very difficult to manage and document. Therefore, to get the valid data became difficult. So, whatever was based on sample size, which are normally recommended for normal disease conditions, but they did not find. So, if you look at the guidelines that are there, CDC guidelines, CDC Atlanta guidelines, there is insufficient evidence to show that remdesivir is beneficial in changing the outcome. The studies that were there, and that was also based on subgroup analysis. So they had a large number, then they subdivided this into subgroups and then analyzed, is remdesivir beneficial. They found that in the subgroup analysis, there was some benefit in reducing the number of stays in the ICU. Apparently. So therefore, to categorically say it is useful, and that too when it is such an expensive drug, and that there lies my problem. So I know of people, doctors who know about these things, who still believe that little grain of hope that is there. You want your loved one to survive, and you're told that you go and get remdesivir, they'll do everything. I know a doctor who spent 1 lakh for one ampule, got 6 lakhs, 6 ampules. 1 lakh for one ampule, got it outside Delhi, didn't get it from Delhi. Outside Delhi, managed to get it. 6 lakhs the poor woman spent, but the husband still died. And if she did not get it and the husband had died, she would have all her life being guilt in her mind. Shayad, if I had got remdesivir, he might have survived. So by doing these unreachable things and telling people to get these unreachable, unprocurable drugs and deliverables, you're creating guilt in a large number of people in minds forever to come. They'll say, oh my God, I wish I could get plasma for my loved ones. I wish I could get it for my son. He would have been alive by today. The doctor requested it. I could not get it from anywhere. There was no good soul in this community who could donate that. Please, I don't think we should get into this kind of a situation in our communities. We don't want that.
So then what we've seen in the second wave is that the gold standard or the most successful therapy has been oxygen therapy. Although there are concerns related even to the oxygen therapy, where doctors try to achieve a 9900 oxygen saturation levels, which is not required. What is the biggest learning on the use of oxygen therapy then?
Biggest learning on the use of oxygen therapy, that everything has a limit to its availability. So when you say that you're ready for capacity full capacity, you may still be having a surge beyond capacity. So you will lead a situation. You have to, the whole idea of preparation, of disaster preparation is when your capacity is overwhelmed. So within that also, there'll be several grades where your existing supply chain management can take care of reallocation, redeployment, rephasing of the deliverables. That's one way. The other is when that supply chain logistic is also overwhelmed, then what do you do? Then you still have to have another plan for it. How do you deal with it? So if you think there is likely to be a third wave, as they are saying, or fourth, whatever you want to call it, you have to be prepared for a capacity beyond what we saw even today. I'm not saying that my hunch will answer that question later on. My hunch, it won't be that bad, but but your preparation has to be robust enough so that you don't land up in that situation. So the biggest learning in oxygen supply was the need for ventilation was far less than in the previous one. That's a very big learning, and you could manage to keep the patient's oxygen saturation reasonably well. The goal was not 99, not 97. You could safely manage somewhere between 93 and 94% comfortably. And that was a very good learning. We didn't have to panic at that level of oxygenation. And some of the learnings about proning and some of the learnings of positioning, all that was very useful in our learning of our need for oxygenation. And in fact, one of the learnings, one of the learnings was that in some of the cases when there was a severe deficiency in the oxygen supply and we didn't know when the next oxygen tanker was coming, what did we do? We went from bed to bed. If he was getting 4 liters, we tried to make it 3.5, just a half a liter without significantly altering an oxygen saturation. So we try to economize by that and then made sure that our people that are likely to change the cylinders are all ready. So most hospitals who had the threat to the threat of oxygen delivery not coming, they were all prepared for the worst case scenario. So that is the learning. So we are prepared for a worst case scenario, but we do hope and pray that it doesn't happen in future.
Dr. Verghese,
And in addition, many hospitals are putting up the oxygen, not the concentrators, because concentrators can at best be 5 liter or 10 liter. And most of the high need oxygen non-rebreathing masks or the high flow nasal catheters cannot be run on oxygen concentrators. These may be considered for post-COVID phase people who can be sent home early and managed at home. They are recovering patients. But what has happened is many of the hospitals, including mine, are putting up oxygen manufacturing plants for various. So we are actually, in a way, preparing for the future wave that is there. Sorry.
no, I was just thinking of walking you back a few steps. Um, a very large number of people complained of having been denied hospitalization despite showing full COVID symptoms because their RT-PCR tests were turning out to be negative. And a lot of hospitals were insisting on positive RT-PCR tests. Now, that seems to be changing. There seems to be a rethink. I mean, Bihar yesterday, for example, allowed compensation to patients who had died, even though the RT-PCR was negative, as long as the high-resolution CT was okay. So there seems to be a realization there. Now, what would you say is at a larger sort of protocol administrative level, this insistence on an RT-PCR clearance before you admitted uh, people to hospital, which might have led to a lot of unfortunate situations in this second wave. Did we go wrong there? And going forward, what do you think we should be? How should we be viewing this?
Yeah. So this is why it is said that in such a situation, your decision making protocols have to be dynamic. Unless you have a dynamic decision making protocol, it won't work. I know it. I know it. It is not might have happened. It has happened case after case. My phone was ringing all the time because people knew I'm helping people in getting admission, getting things, getting access, getting things. I was helping people. And my phone was right through the night for 2 to 3 weeks. I barely slept for 2 to 3 hours in the night. It was really heart rending. They'll say, sir, सांस फूल रहा है, saturation 76% है. वो कहते हैं COVID test report नहीं है. The report is not there. You can't be admitted. Which I felt was so sad, so disheartening, and must be so difficult for the relatives to. And again, remember, many of these patients in this epidemic, they were not the relatives who were bringing, because all the relatives are positive at home. Some good Samaritan was bringing this person in an ambulance, and they would wait in the ambulance, and the ambulance would be running out of oxygen. Sir, please, oxygen khatam ho raha hai. Sir, oxygen is finishing. Please do something. Can you do something? So then I'll have to request the emergency to chip in and do something to help with their oxygen supply. So these are real time things which should have been real time helpline monitored. Where is the problem? What is happening? How do we deal with it? How do you deal with it? Should have been done. And right in the beginning, the moment you saw the look at the graph. In fact, I love showing this graph every time. Look at the graph. Can you see the earlier wave is this wave,
Yeah.
so flat, and this wave is so sharp. Just from the rise in the number of per day cases, I said, my God, this is going to be way beyond capacity. And in fact, early on, I did tell one of my friends who is close to some people that are in power, I said, I think we won't be able to manage. We'll need to call in the army for help. I did say this to one of my friends who was close to some powers that be. This was a situation I felt that we needed big time help, maybe from states that were not affected, from states that we needed big time help, because the upswing of the graph was clearly telling you that you're in for a big time trouble. And also once we see this, and this is the time when our hospital data collection, our hospital, in fact, mucormycosis became a notifiable disease. Okay, so you had to give daily notice on the number of cases of mucormycosis. Similarly, to make this notifiable, I would have suggested, how much does it cost to have an iPad or one of those cheaper pads that are there? Every hospital, every doctor, every ward should have an iPad with real-time connectivity. It wouldn't have taken you long to prepare that. Real-time connectivity. Somebody intelligent should. The problem is the intelligent people are all taking care of patients. The others, they were grossly outnumbered. So this is the learning from this, that we need to create systems that are dynamic, which can capture data real time across the city, and there should be a nodal control center where it is not for fault finding. No, I don't believe in fault finding in that way. I find in system corrections and system evaluations. So don't call it fault finding. Don't call it a witch hunt. No, you'll only have some poor scapegoat being found and then punished for that, but the system will not correct. You need to have a system correction by looking at a system evaluation. Intelligent system evaluation will come from people that know how to gather and analyze large data. Data crunching is important. So you can get people, there are enough people in this world now who do large data crunching, who do analysis of data, large number of clinicians. In fact, some of the best clinicians, the clinical departments in the West, they don't have just clinicians. They have clinical research professors associated with them. How many research professors who do only research are there in our medical colleges and our healthcare infrastructure? We do have one or two institutions, one or two ICMR, that's one building. But how many are there which can go across medical colleges, research positions, who walk down in the ward with the clinicians, who are not looking after patients, but also with the patients, engaged in research work? That would have told you what is happening. That would help you make decisions and make it dynamic. I would have had, instead of having paper, in fact, I think I'm in one of the task force meetings, it was recommended that we will have an iPad or whatever. I don't want to use commercial names. Any one of those pads digital pads that are there, which will be used by the people inside the ward, which are COVID. You don't have to go in with PPEs and bring the information outside, directly transferred to the person outside with a similar digital pad that is there. So this is what could have been done. Here we could have leapfrogged into the next level of medical record keeping in the last 1.5 years. Long answer, sorry, but
No,
I
no,
think
no.
it was important.
No, very, very helpful, sir. You mentioned mucor. Uh, a lot of people have been, I'm sure, would want to know. Now, this supplementary fungal infection, mucormycosis, I'm not sure too many people had even heard of this before this happened. And now we are in a situation when the second wave seems to be, thankfully, waning. In fact, sometimes we feel that on certain news days, we feel that we have more stories on mucormycosis than we have on the infection itself. So, why did we see this sudden surge in these fungal infections?
I wish I know the full answer. We can only guess the possible reasons. The You said very correctly, no one would have heard about mucormycosis before. You talk to an average doctor 2 years back, they wouldn't have seen a case. As a medical college resident doctor, I saw one case in my 3 years of residency. One case in 3 years. If you took the statistics in one medical college, they might see 4 to 5 cases in 1 year. So the numbers that are seen are very few, and the critically ill are very few. And who are these patients who are usually seen in medical college hospitals? These are tertiary care facilities where they are seen. These are patients who are diabetics, who have very poor diabetic control, who need the the support system for a ventilation and or oxygenation, and need broad spectrum antibiotics to correct their septicemia, who are in probably renal shutdown, multi organ failure, immunity is really down, and then they develop this. The fungus is not, people say it is from industrial oxygen. There is no evidence of that. If that was so, Gujarat would not have the highest number of cases some time back. They had the highest number. They did not use industrial oxygen cylinders. Maharashtra did not use industrial oxygen cylinders. There were any number of states never having seen an industrial oxygen cylinder in a hospital getting the infection. So that was not the reason. They were blaming the humidifiers. That was not the reason. The virus is ubiquitous. It is there in your soil. It is there in your plants. It is there in your air. You have a moist piece of bread putting out on your windowsill. 2 days down the line, there will be a growth of a fungus there. 2 days down the line, 3 days down the line. All that the fungus need is one, warmth, two, moisture, but that's not sufficient. It needs food. Food is either starch or glucose. And fourth, it needs an acidic medium. In a diabetic patient who is immune compromised because of diabetes, in a normal situation, and his diabetes is out of control, they get into acidosis. And that is an ideal environment for the fungus to, the spores which are ubiquitous in your air, that will then multiply in your mucosa. And that is wet and it is warm. It multiplies. But in this particular case, why did we see so many? We have any number of patients on steroids. We have any number of diabetics, any number of renal disease patients. We have any number of patients of cancer on immune suppressive therapy. But we do not normally see them in there. So what is it that made a difference here? That is why I'm saying I wish we know the answer. Probably, and one thing that happens is when you give antibiotics to these patients, normally your normal body has a lot of bacteria. So that is a logic behind all these probiotics that you're familiar with. Probiotics are just concentrates of bacteria of different kinds, but they don't cause disease. That's why it is a probiotic. Similarly, there is a large flora of bacteria in your windpipe, in your trachea, in your bronchi, in your lungs, but they don't cause any disease. But they have another role. They prevent other organisms from coming over and taking over. So their presence prevents that. So when you give antibiotics liberally, without indication, and on top of that give steroids to suppress immunity, On top of that, there's diabetes. On top of that, there's ketoacidosis. You have the setting for mucormycosis. In addition, that's still not sufficient. We think possibly this virus is doing something to your immunity. It is contributing to some immune compromise, and therefore, mucormycosis is more common in this setting.
So, I think one more question. After that, we can move to the audience. I think for a lot of people, this is probably the most awaited one. Third wave, you have mentioned it, and children. So, two questions. Do you think that a third wave is coming? And if it is coming, when? Two, is there any basis to the hypothesis that children will be affected more by this third wave if it comes?
Okay. I'll look at history. No plague has gone on forever. No influenza has gone on forever. You look at any number of historical evidence. It has taken its toll. Okay, so in this situation, almost quarter of 4 lakh people have lost their dear ones. 3.69, I think, is the statistics for today. 3.69 lakh people have lost their dear ones. I've lost some of my very dear friends, which is, irreplaceable. And I really am really devastated and traumatized by that. But to think that this virus has gone around for 1.5 years now, such a large toll has happened, and so many have been infected. So many have been symptomatic and infected, but many more may have been asymptomatic and infected. My own PG was telling me, sir, I had no symptom at all. I was exposed, I got tested positive, but I had zero symptoms. There will be so many like that. So the virus produced no symptom in many, and that would have contributed to immunity. Herd immunity is a concept which is theoretical, based on the R naught factor that is there. If your R naught is this much, you can think of a herd immunity at 60 to 70% of the population being infected. But that is not the only dynamic. If you look at some of the researchers in some of the communities, when far less number of people had infection, herd immunity was achieved. So the disease dynamics will need to be studied. That is why the importance of research in this. Here was a gold mine for research in this. We won't get this for another millennium, I'm certain about this. And therefore, my next answer, will the next wave come? I predicted this wave will go down in the next 30 days. I predicted, and I am proven right in this. I know that looking at the surge, last wave, this wave, and the protection from the vaccines that are being rolled out, we will reasonably have a manageable wave, barring an unforeseen, a devilish strain that comes up, which I cannot predict. I will have to be a medical astrologer for that. But barring that, I don't think there'll be a massive surge like this, and we don't have to be worried. And if at all it is coming, it will not come in the near future. Why am I saying that? In the 350 odd cases that have been following up, I've had 3 cases who got reinfection. One lady got infected in the last April phase, got infection now almost 1 year down the line. Another 2, 5 months back, they got infected, have come back and got reinfected. So they are having a reasonable protection after the infection for at least 5 to 6 months. So this large mobile population who, like honeybees, taking nectar from one flower to the other, taking virus from one human being to the other, from one home to the other, these ones have, most of them have been infected, and therefore they would have sufficient immunity to protect them at least for 5 to 6 months. So I don't think you need to worry for the next 5 to 6 months. But having said that, that should not make you complacent. It is your complacency which will land you in trouble. We cannot afford to be complacent. That is important. We need to have this as our protection under any circumstance. Don't give this up.
Yes, sir.
Because don't think you're vaccinated and therefore you're protected 100%. No vaccine company gives you 100% protection. Covishield is about 70%. Pfizer is about 90 to 93%. Moderna is also 90 to 95%. Every Covaxin, all of them have that gap that is there. So if a lot of people say, my brother, he had both the vaccine and still he got the disease. Many of them got a mild disease, but many of them had serious disease also. But that will be the 30%. When you see 30% is a large, 30 out of 100. Look at the number of people that have been vaccinated in India so far. They run into millions. So out of million, that 30 would be multiplying into several numbers. So don't worry. Therefore, this becomes your key protector until the entire fear of the wave across the globe goes off. Protect yourself. That's so. The chance of the virus coming as in the next surge is very low. In the near future, maybe 6 months, 7 months down the line, there'll be an additional wave, but not this big. Not this big at all, as far as I understand. And to conjecture that children will be affected, it's an absolute shooting in the dark, where you have no clue what you're saying. There is no evidence, there is no signs that children are going to be affected. In this wave, what did we see? A large number of children affected. Did we see large number? I did see. I saw many children being affected in the large wave also, whom I handled myself and didn't have any symptoms. They had corona positive because I wanted to operate them. When I tested them pre-surgery, they were positive. They had no symptoms. The mother said, no, isko to kuch nahi hai. There is no problem here. No, this test is positive. And therefore, we had last time also. This time the numbers were much more than last time. I had a 1-year-old baby also admitted in our ICU. So we had much more, but the total numbers are also more. So out of a percentage of a large number, so we need to look at the full data, analyze it intelligently to say, is the number of children affected in this way more? But to predict that the future is going to be like that, I would like to challenge all of them. Could they predict this wave? If they couldn't predict this wave, how do they say, on what scientific basis do they say they'll predict the next wave? And what bigger science do they have to say that it's going to be children? So the message out to people is there is no evidence to say that children will be affected. I can think of a very suspicious way of saying this. 40%, the actual number is 38%, of children in India under 35, under 15. Under 15 population in India is 38%. And that in a 1.3 billion population is over 400 million. 400 million captive population who can have the vaccine. We as yet don't have a vaccine which is tested in children. We have started the testing. Very rightly so. We are doing it. We should do it correctly. But we don't have a vaccine available in India right now. So if somebody internationally wants to spread a rumor that children are going to be affected, out of parents' love for their children, they'll do anything. They'll spend the money and get that vaccine which is tested in children abroad and give it to their children. And I don't think that this fear psychosis being created needs to be created because parents will be forced. So the upper class will take their children abroad, spend money and get their children vaccinated by children's vaccine that is available. That is what is going to happen. Or they'll procure by hook or by crook vaccines for themselves. So this is what we need to avoid. We need to clearly say there is no evidence. There has to be a clear policy coming out from the powers that be, that we don't believe in. Dr. Guleria has very nicely clarified in a newspaper article that there is no evidence. He has really clarified it. And that message needs to go across the country. Dr. Guleria, the chief of AIIMS, has clarified it, and that needs to be spread across the country. There is no evidence for children being affected in the next wave. The next wave itself is hypothetical, and children is pure conjecture.
That is most reassuring. So next wave, if at all it comes, it's not coming really soon. It's going to be much less probably from this one, and there is absolutely no evidence. Fantastic. So Conrad, shall we go to the audience questions? We have yeah. So we will start with Dr. Kirit Parekh. Dr. Parekh, are you there? Dr. Kirit Parekh, sir.
So please unmute yourself.
No? Okay. Maybe we'll come back to him. Shalini Singh, are you there? Shalini Singh?
Hi, can you hear me? Hello?
Yes, we can.
Okay, great. So my question to Dr. Verghese is, could you tell us a little bit about long COVID? I mean, from my observation, and perhaps I'm wrong, that would it be right to say that those who get COVID and recover within a few days remain okay, while if it lingers for those, then it just turns into long COVID? I mean, just if you could share a little bit about that, please.
Yeah, we're still understanding the long COVID symptoms because many patients are coming back with long COVID symptoms, and then we find that okay, they had COVID. So the commonest that we are seeing is tiredness, body aches. Myalgia is the expression used. Myos means muscle. Algesia refers to pain. Myalgia means painful muscles. So when they try to do something, it aches and pains. Doctor, I feel like a 70-year-old. I feel like an 80-year-old. I don't feel young at all. It's so difficult to move. They have backaches. They don't have joint pains as much. I've seen only one or two patients with joint pains, but most of them have body aches. A lot of them have tiredness. The tiredness can be because of two reasons. One, because of the fact that they have body aches, muscle pains, but it can also be because their lungs were compromised significantly. And these are the people who will have CT scores in the high, moderate to severe. CT score not on the RT-PCR test, that is not at all reliable, but the CT scan CORAD score, which is if they have had a CT scan done, that would show that the score is somewhere between 15 to 25. These are the people who will find that when they try to climb stairs, they get breathless. When they walk long distance, they get breathless. So their capacity to move is less and therefore they are tired. So this category are the ones who had the illness, significant disease, needed hospitalization, needed oxygenation, and therefore had lung compromise. There are others who did not have that, many of them who had thrombotic phenomena, clotting phenomena leading to a stroke. That is a paralytic condition. Clotting phenomena leading to an MI. That is a long-term consequence. Leading to a myocarditis that happens, a cardiac damage that happens, autoimmune reaction happening around the fourth week or so of the illness. So these are things. So therefore, what do we tell people? Immediately after they've gone back home, even the milder ones, we tell them not to do vigorous exercises. Vigorous exercises because the prothrombotic phenomena. What do you mean by that? Thrombosis is clotting of blood. The tendency for clotting of blood in these patients remains for 3 to 4 weeks. That is why the anticoagulants are given from 3 to 4 weeks in these patients. The steroids are given for only a week to 10 days, not longer, because they create problems. They're diabetogenic. We don't want that. But the anticoagulants are continued longer because many of them have cardiac problems, could be thrombosis of the coronary arteries, clotting in the coronary arteries, or they could have a myocarditis. So these are people who have cardiac symptoms, whose heart rates go into tachycardia, which means, sir, my palpitations are there. Or they'll say, sir, my heart rate is 46, 50, it has gone down. Most are benign, most are self reverting, but you do not want to ignore it. You take the help of a physician and take help. So, all these are conditions that come under long COVID. We are also seeing another pattern of patients presenting with, that's rare. I've seen only one patient. There's a rare syndrome called Miller-Fisher syndrome, where there is eye involvement plus paralytic condition. The patient was referred to me. I couldn't prove it because the symptoms were fitting in and the history of fever was there 4 weeks back. So the setting was there, and my suspicion is it was the Miller-Fisher syndrome where paralysis like polio with eye involvement was there. So ophthalmoplegia with paralysis, that's a rare syndrome. Also, we're seeing in children a rarer syndrome, which is there in some patients, Kawasaki disease, which is a disease of blood vessels, all because of clotting, tendency for clotting. So this virus is sinister, as one of my colleagues in radiology puts it. It's a sinister virus, causes all kinds of problems, and most of these are related to the autoimmune reaction. Auto is self, immune is your ability to fight disease. So your body is creating antibodies which fights your own cells within your body, considering them as foreign. So the long COVID can manifest in a myriad of symptoms, and some of them with clotting in the intestine can present after 2-3 weeks with an intestinal obstruction or the dead portion of your intestine needing surgical intervention. So many of these are acute, post-acute presentation, but many of them do have symptoms appearing beyond 4 weeks also.
Thank you. Dr. Huma Hassan, are you there? Dr. Huma Hassan?
Yeah, hi. Am I audible now?
Yes, you are. Go ahead, please.
Yeah, thank you so much, Dr. Varghese, on enlightening us with such a precious information. I'm so glad that I participated in this webinar. So, I have two questions to you. First of all, I want to know, as you know, that there is a lot of information and misinformation, right, out there related to COVID-19 pandemic. So, my question is, first of all, that do pandemics usually have second or third waves, or this is very specific with COVID-19 case? My second question is that you said something about Schindler list, right? It seems so kind, and it seems like, I just want to know that how you have done it. But yes, this is probably the best thing a doctor should do. But with such a massive number of cases, Dr. Varghese, how you have done it? This is a great message to the masses, right? Because it is not something that you have gone beyond your capacity. Making a call in the morning and then checking up in the evening. So this is what you have to do, as a doctor. But I just want to know what was the mechanism, by which you have done that.
Yeah.
So that
actually,
others can also learn.
If you saw my description, I'm an orthopedic surgeon. I could do it because I was not doing day-to-day. So all the physicians and physician-allied specialties were busy taking care of those patients. They were all busy. They didn't have the time. They were doing rounds, PPEs. It is terrible out there in that field out there. It is terrible. Going through that is terrible. I, as an orthopedic surgeon, I never closed my OPDs. I still had my outpatients. I was seeing my orthopedic patients. But the time I had, I utilized to counsel patients. And I realized it soon because one of the earliest patients I spoke to, she said, "Doctor, that's the first time I'm sleeping in 2 weeks. I have been petrified that I'm going to die." 2 weeks down the line, I said, "Please remember, nothing is going to happen to you. Your disease is 2 weeks behind you. You can be at peace. You're a corona warrior now." That statement made such a relief to her. Then I realized the importance of counseling. And that is why when your learnings in this exercise has been to have such counselors who are not at the front line. I was not at the front line. I was at the front line in terms of counseling for COVID. I was at the front line trying to arrange help for people. I was at 3 a.m. in the morning. I was arranging ambulances for people. They didn't know where to go for. They said, "Sir, we have tried. We can't get ambulance. Can you help us?" 3 a.m. in the morning. So I knew some people who could help ambulances and I could arrange. It was sheer trust they had in me, and I had to deliver. I had to deliver. So this is what was required by a system being created for that. And therefore, that is why I show this every detail is there date wise. If you see the name of the patient, the time, and the first symptom, second symptom, what medicine was started at what time, I followed up. And because the numbers initially were small, I could remember. Then I realized, no, I can't remember. I started writing. And everyone, so I had kept adding. Okay, then I suddenly remembered the Schindler's List. Then I realized, okay, this is what meant by saving people, by helping from outside. I could do it from outside. I was not a frontliner in the ward wearing PPEs. I was not in the ICU. So I had the oversight talking to doctors. I talked to every doctor. I went to the radiology department looking at the CT scans. And that's some message I want to give here. There is two of my friends, Dr. Bohia and Dr. Tej Prasad Sinha, outstanding doctors in All India Institute of Medical Sciences. They have this fantastic ultrasound system, point of care ultrasound for evaluating these cases. This has not been publicized sufficiently because every district hospital could do that. You did not need a CT scan also. These are fantastic researchers who have this fantastic work, but somehow it has not got popularized. I think it should be popularized by people where you can assess the damage to the lungs without taking them onto a CT scan, without taking them onto the whole radiation risk, especially women. The radiation risk is 400 X-rays plus, depending on body size, it may go up to 800 X-rays. Is the radiation from one CT scan? You could avoid that. So to answer that question, I could do it because I was not in the akhada, as you can say. I was outside watching, talking, patients, doctors, everybody else. I could do that. The first part of her question was the um, sorry, just remind me on the first part of the question.
Moment. So my first question was like, I want to know that, do pandemics usually have
Yes,
this
the second
or
wave.
third waves?
Yes. Depending on, but see, the viral diseases, remember, viral diseases do not as yet have any drugs for them. The first virus was discovered in the beginning of the last century. That was the tobacco virus, if I remember correctly. Till date, we have vaccinations for viral diseases. We don't have a true antiviral drug. People don't understand this. It's not a bacteria which can be killed by giving an antibiotic. It is not a bacteria, it is a virus. Why? Bacteria exists outside, has a life outside a cell. Virus has a life only when it enters and becomes a part of the cell. To kill the cell is the way to kill the virus, but you can't kill your body to kill the virus. Therefore, the viruses have to rely on natural immunity of your body. So, depending on the immune people in the community, you may have 1, 2, or 3 waves. It is possible. And if there are populations like polio, for example, you have eliminated from large populations around the world. Vaccination has been done, but you're not eliminated it completely. So if there is a one pocket of virus, it can spread around and affect people that are less immune. Therefore, your waves will depend on the numbers that have sufficient immunity to break the chain of infection. Or if there is a weak link, that link will have the infection and create another wave. So please be prepared. Those communities that have not had waves, which are large, should be prepared and have sanitization and masking. Not just a little piece drop there and this. No, well done, liberally applied. But this is better to have soap and water, or better, because the virus is very, very sensitive to the soaps that are there. Any soap or detergent kills the virus immediately.
Thank you. Sushil Prakash, Mr. Sushil Prakash.
Can you hear me?
Yes, go ahead, sir.
Yeah. First of all, I would like to thank Dr. Verghese for a very insightful presentation, insightful discussion. My question was very simple. That the reference the vaccination against the COVID-19 virus. You did mention about the children, there being no cure for the children. What about the pregnant women? I mean, is there any recommended vaccine or any recommended treatment for pregnant women?
Yes. These antiviral vaccines have been created in record time. In medical history, if you see, vaccines have taken years and years. If you saw the polio epidemics going on throughout the 30s and the 40s, In somewhere in the middle of the 50s, you had the first killed virus vaccine for polio. It's a fascinating story of vaccine creation. It takes several years. Why does it take several years? Because drugs or medicines are given to people that are ill, unwell, and therefore you can accept a certain risk in certain side effects. Vaccines are given to normal human beings. Therefore, the safety profile has to be way above that of drugs and chemicals. It has to be way above. So, to create that level of safety takes time. That is why you have phase 1 trial, which looks at side effects, phase 2 trial, phase 3 trial, which looks at efficacy, and the rollout in the population. But that's not sufficient. Polio virus vaccine needed an approval to be released in the community, and one of the earliest communities which was released was in Russia. In Russia, and several communities in the US. It was released out. Speculations on problems, on paralysis, all those were there. But they tested out, looked at the data, and came back with the safety. So, did we do a trial in pregnant mothers and lactating mothers? No, we did not do a trial. Why? Because the safety profile for the ordinary human being was also not known. So, we did not want to risk that special vulnerable population. We did not want to risk the children. We risked only the young, healthy adult or the vulnerable group, that is 45 plus, not the 60 plus. So, we tested them by and by, and we now have reasonable safety data on all of them. But in the trials that were early on, some of the people who were given the vaccine early on were found to be pregnant. They didn't know they were pregnant. They were found to be pregnant. Or they became pregnant during the course of between the first and the second dose. They also did not know that. So when they reported back their pregnancy, the researchers who were following up the complications and side effects, they don't call it complication or side effect, the term uses adverse event for immunization. And they looked at them and followed them till the end of their pregnancy. They did not find any birth defect or any other teratogenic effect, as they are called, birth defects or other complications in these pregnancies. So the pregnancies concluded normally, the children were born normally, and that gave them reassurance that these vaccines are safe even during pregnancy. So these early reports were from the Pfizer and the Moderna vaccines. They are having some reports from the Covishield, which is the Oxford AstraZeneca, and the Covaxin trials are going on in children now. Dr. Guleria has announced it. That is happening now. So we are working on it. People are working on it. Researchers are working on it. But the recommendation is the virus takes a dangerous turn and have a bad outcome in maybe 0.5% of cases, which means 1 in 200 people can have a very, very bad outcome. What the adverse event following immunization? Probably 1 in 100,000. So when we look at risk versus benefit, the benefits of having the vaccine is far better than having the disease. The outcome of pregnancy after a virus infection from COVID is really bad because you're dealing with 2 lives here. So the number of cases that in our hospital that we dealt with, we had stillbirths, we had mother and child both dying, we had the child dying and the mother surviving. All bad situations. We want to prevent that. Only safety precaution that we say is if you know you're pregnant and this is the first 10 weeks of that knowledge, then avoid that vaccination that first 10 weeks. After that, get your vaccination. It is recommended that you take the vaccine because the protection from the vaccine is far better than having the risk of the disease.
Thank you. Chitra Khanna.
Yeah, hello.
Yeah, go ahead,
Yes.
please.
Yeah, I have a very simple question. I've been too anxious and I don't know what to do with it. A bit of fatigue in any family member, or even a bit of a cough in any family member, and the alarm bells start ringing. So how do we manage it? Though we know it's around, we take all precautions, but how do we manage this anxious situations?
I did a research project on this early on, last May, for 1.5 months, 3 months. We surveyed families of persons with disability, families of persons with disability and their caregivers. And in this survey, we surveyed over 3,400 families. Data captured on each one of them, and multi-centric, multidisciplinary, which included blind people, deaf people, physically challenged people, cerebrally palsy people, intellectually challenged, mentally ill people. Every spectrum was there. You know, the number one problem that we found, difficulty in sleeping, anxiety, worry. These were very high in the list, in almost as high as 90% had problems. So the moment you have gone through corona, that worry gets multiplied. These are people who may or may not have corona, but who were surveyed. But they had worry as the number one symptom because it takes away your dear ones. You're petrified. I was petrified of phone calls because I was worried who is calling me for what? Is it a terminal person? What is it? So, as a physician who knows so many things, I was worried. So, as a lay person, I can understand your worry. But worry is normal to a certain level. So, if it is going beyond 2 months, if it is disturbing your sleep, then you need help. 4 weeks, you're recovering and your tiredness is there. In about 2 months, maybe it should settle. But even in that 4 week period, beyond 4 week period, if you're not able to sleep, not to get a good night's sleep, you need help. You can go to a trained counselor. So we need to get the stigma out of this seeking help for anxiety. It is a symptom which can be handled, which by talking to a counselor, and I was being a counselor to many of the people, patients, and they said, Doctor, we are so grateful. I didn't have to give them a sleeping pill. All I gave was talk to them, reassured them, don't worry, you're doing well. You will recover. You will recover to take. Their worry was, what will happen to my child? What will happen to my disabled child? Nobody will be looking after them. So it is normal for people to have this kind of a worry. But if that normal worry gets into the pathological domain of lasting too long or becoming a problem in your normal sleep and activities of daily living, you need help. Seek help from a trained counselor. And if you need help with medicines, the counselor will put you in touch with somebody who will help you with that. So this is something you should not think of as a stigma. You're mental. No. It is normal to have worry. That tells you, in fact, people tell me, you're worried. I said, no. I'm comfortable dealing with people that worry, people that are emotional, because I would rather deal with emotional people than people that are cold blooded.
Very important. Thank you, sir. Ashwini Gupta. Ashwini Gupta, are you there?
Please unmute yourself.
Can you hear me now?
Yes, sir. Go ahead.
Yes.
Good evening. Sir, my question is, this pandemic has taken a heavy toll, and you have spoken about the reduced chances of a third wave. But my question is, in a limited form, in a reduced form, like flu, for example, will this virus continue to bother us even after 4 or 5 years?
Only time will tell and history will bear witness to the future. I can't predict that. But by and large, most such viruses have actually faded over a period of time, except for the very mild ones. Remember, it is in the interest of the virus to have a low degree of infectivity, which causes low degree of disease severity, and they live harmoniously in community. A virus which causes high mortality is likely to be fading away faster than a virus. So evolutionary trends tell us that we have hope in this the sustenance of the race. Even for the virus, it is good to have less severe variants surviving and creating immunity naturally. Remember, the virus caused only mild symptoms. It is the immune reaction provoked by the virus which made the disease dangerous. The virus itself is only mild, but that itself is not good for the virus. Therefore, we hope the future variants will not provoke that. We hope we'll find a way to counter that immune reaction without all the side effects that we saw: mucormycosis, ketoacidosis, diabetes, renal dysfunction, all kinds of problems. We hope medicine will evolve in the future to a more mature medicine with less complications.
Okay, so I think we have time for one more question. Shubham Sinare, are you there? Shubham?
Shubham, please unmute yourself.
Am I audible?
Yes, go ahead.
Hello, sir. My
Hello.
question is, can diabetes mellitus cause any complexity in the recovery of COVID-19 and mucormycosis? And if so, how is the immune response of diabetic patient is different from others?
The diabetics normally have white cells. You see, in our body, or when you have a boil in your hand, there is pus that forms. That pus is because of the fight between the white blood cells and the bacteria. It's the dead bacteria and the dead white cells that are there in the fight that is happening. So white blood cells help you fight infections. So these white cells in the diabetics have poorer capacity to fight infections. So therefore, diabetics, even if they have infection, they don't always show the degree of fever that others show. They may have a bad infection, but the fever severity may be less because the reaction produced by them is less, because the immune system is less capable than in the normal human being. So the disease seems to be that only of a sugar? No. It is a disease which affects every system in your body, including your immune system. Having said that, during the acute treatment for a cytokine storm patient, we give steroids, we give anticoagulants. These are patients who will have poor control of their diabetes. But the steroid should be stopped in a week to 10 days' time. Do not continue it. If you continue it, I have seen patients 3 weeks, 4 weeks, ask them, send me the prescription. There, sure enough, there is steroid being continued beyond 3 weeks. No, don't do that. That will create haywire with your control of your diabetes. So diabetic control should become normal by stopping steroids and having diet and your diabetologist or physician taking care of your medicines properly. However, many of these patients have body aches. Many of these patients have tiredness. They can't go for normal walks. Today also I saw a patient. Doctor, I can't go for normal morning walk. So what do I do? Then you will have to tinker with your medicines and with your diet. If you're not exercising that much, you need to reduce your calorie consumption. So you need to be in close touch with your dietitian, with your diabetologist to ensure that your diabetes sugar control is good. So post-COVID can affect your diabetic control by reducing your ability to do physical activity, by lung capacity being reduced or physical capacity being reduced because of body aches and pains.
Thank you. Dr. Varghese, absolutely wonderful, very informative, very clear, and I have to say, extremely reassuring. Thank you so much, sir, for
Thank
doing
you
this.
for having me.
Thank you very much,
Thank you,
sir.
sir. Thank you.
And thank you to our audience. Some wonderful questions. Some of you should be sitting where Conan and I are sitting, and maybe next time around should be asking someone like Dr. Varghese these questions. And thanks very much to our partners, Kia Biotech, Plutus IAS, and ITM Group of Institutions. Thank you very much. Thank you, Dr. Varghese, again. Thank you so much.
Thank you, sir.
Thank you so much for having me.
Good night, sir. Good night.
Good night. Good night.